Okay, good afternoon, everybody, and welcome to today's webinar on lessons learned from the 2023 worldwide EQA schemes for molecular testing of BRCA and other HRR gene variants in ovarian and prostate cancer. So it's my job to do the housekeeping. So let's go to the next slide, please. So as usual, we have muted your microphone to avoid any unnecessary background noise. We are recording the webinar as normal, and we'll make it available to you shortly after, and usually a week to 10 days after the webinar has taken place, through our normal channels via the EMQN or GenQA mailing lists. And as always, again, the key part of these webinars is your interaction with us. So you have the ability to submit your questions via the Q&A function, which we have some time dedicated at the end of the webinar to go through those questions. So please do so, encouraging you to ask your questions, and Sandi and myself, my co-chair, will answer those at the end of the session. Next slide, please. Your feedback is also important to us because it obviously helps us shape future webinars and ensure that we're meeting your needs as well as the other allied healthcare professionals. So after the webinar, you'll receive an email with a link to a short feedback survey. It takes about 2 minutes to complete. Please, would encourage you to submit that and feedback to us directly. Okay, next slide, please. Right, I'm going to hand over to my co-chair, Professor Sandi Deans, for the introduction.
Thank you very much, Simon. So just add my welcome to Simon. So Simon's the CEO of EMQN, and I am the director of GenQA. And together we jointly provide the EQAs for these molecular testing BRCA and HRR gene prostate and ovarian cancer EQAs. So next slide, please. This is a disclaimer. Thank you. Next slide. So, as I said, this is a collaboration between the two global EQA providers, and what we actually deliver are 3 separate EQAs, so that's external quality assessments. So the one that we've been providing for the longest time is the germline and somatic BRCA testing in ovarian cancer, and this is now the 8th year that we have provided this EQA. For 4 years, we've also provided an annual scheme for somatic HRR gene testing in prostate cancer specifically. And these are all supported by an educational grant through AstraZeneca. The format of the EQAs are all similar. So what we do is we provide 3 different samples per sub-scheme, and we distribute them with a corresponding clinical case. So it's not just about testing the samples, it's also about interpreting them in the context of the use case and the referral form that's coming into the laboratory. And really importantly, we don't want laboratories either to set up new tests or do anything different than the routine normal testing protocols and practices, because this way we can actually give you a true measurement of the standard of your clinical service. Now, these schemes have grown from strength to strength, and we now have an independent assessment team who assess the EQA returns anonymously against harmonised peer-reviewed marking criteria. And we've now got 36 different assessors from 14 countries, which is fantastic because the real benefit of this is having the expertise and knowledge, and also the perception and the knowledge and the guidance that is coming out of the different countries. And as we have participants from many, many different countries, it's very important that we include this when it comes to the marking the EQA returns. So next slide, please. So the main principles of our EQAs are we are providing the same samples, so the same starting EQA material for testing to all participant laboratories. And this means we can actually benchmark and make comparisons across the results and the interpretation provided by the laboratories. We return results to each scheme for the return results for each scheme are then assessed, as I said, through our peer review criteria and in an anonymous fashion, so nothing is skewed if an individual knows that particular laboratory. And as I say, it's really important to treat these samples in the same way as a patient sample coming through your clinical service. The EQA results are scored, everything's scored out of 2, and really that's to determine the accuracy of the laboratory. So it's whether or not you're obtaining the correct result with the correct interpretation and clinical advice on the report. So what's the advantage of performing EQA assessments? Well, really it gives the laboratories an external measure of the quality of their clinical service. And also because we can actually tailor some of the EQA cases and the samples that we provide to particular issues or needs, or perhaps issues with testing, we can actually provide that continuous education and training to the whole of the workforce. We also apply performance monitoring across the different EQAs and also between years. And really that's to provide regulators, commissioners, service users, and many other key stakeholders with information on the EQA performance of the laboratory. And we can actually take some steps to help educate and also provide developments and develop service improvements really for the laboratories that are participating. So next slide, please. Simon, I'll now hand over to you for the update on our first germline EQA, please.
Thank you, Sandi. So for the benefit of the participants, myself and Sandi are going to take each one of the different EQAs and run through the results for you. And at the end, we're going to pull it all together with a sort of summary that rounds up the entire cohort of 3 EQAs and the lessons learned that we've taken from that process. So I'm going to go through the germline scheme to kick starters off. So next slide, please. So just a little bit of background really on the numbers associated with the scheme to give you a feel for the scale of what we're trying to do and the reach of interest across the globe in this EQA. So we've been running this scheme for sort of 9 years now, and you can see that this last year we had our highest number of participations ever. About 330 laboratories participate, of which about just less than a quarter of them were new laboratories, had never participated in this EQA scheme before. So obviously what we're looking to see is a reduction of the purple and a growing number of laboratories in the blue, representing those laboratories that participate on a regular basis. So we're getting there, and it's certainly improving compared to previous years. And when you look at the demographic split of the laboratories, the biggest difference really between 2023 and 2022 is a 6 or 7% increase in laboratories from China and a small increase from the EU and across the other geographical regions. So in essence, a larger number of laboratories participating in China this year compared to last. Next slide, please. So the format of this scheme, this germline scheme, is that we send 3 genomic DNA samples. These samples have been taken from lymphoblastoid cell lines that we have established in the EMQN cell bank back in Manchester. We've selected them based on known variants. So when we design the EQA scheme, we think very hard about the strategies or the questions we're going to ask each individual participant, and we'll come on to that very shortly. But what you need to know is that all those samples prior to being distributed to you have been independently validated by at least 2 different laboratories, including copy number analysis prior to distribution. So we used 2 different laboratories last year, one using an Illumina MiSeq strategy and a custom panel from Sophia Genetics, including CNV analysis, and the other using, again, an NGS workflow, but this time using a larger scale sequencing strategy and a custom adjuvant SureSelect assay, with additional confirmatory testing performed using Sanger sequencing and MLPA analysis for CNV analysis. Next slide, please. So let's go through the cases individually one by one. So case 1 was a lady who had been diagnosed with serous ovarian cancer, received platinum treatment, and the tumor had responded. She's now being considered for targeted treatment as a maintenance therapy. And the rationale really for this case was maintenance therapy after first-line treatment with platinum therapy, i.e. this patient hasn't relapsed. So is there a pathogenic variant present, and will she respond to the use of PARP inhibitor therapies? Next slide, please. So this case contained a large CNV, so a deletion of exons 1 to 11 in the BRCA1 gene, and no pathogenic variants in the BRCA2 gene. Now, our rationale for including this sample is that as we've talked about in many previous EQAs and demonstrated from the results, is that CMV testing should be undertaken, certainly in the germline setting. The published evidence shows that up to 20% of all variants within BRCA1 could be a copy number variant. So the inclusion of copy number variation testing in a BRCA strategy, certainly in the germline, is mandatory is perhaps too strong a word, but strongly advised. And the latest hereditary breast and ovarian cancer guidelines strongly recommend the use of CMV testing in this context. So as you can see from the results, the genotyping results, 10% of laboratories failed or made a critical genotyping error. In other words, they did do CMV testing and failed to pick up this very large exonic deletion. Another 19% of laboratories did do CMV testing, but didn't report the CMV but the data was correct within the limitations of the test they had used or stated on their report. And about 70% of laboratories got correctly reported the result correctly. Next slide, please. So when you drill down into the reasons for the genotyping errors, they largely fall into three areas, false negative results, false positive and/or false negative results, and laboratories that have undertaken a CMV analysis strategy but have incorrectly reported the extent of the deletion for that case. So in the false negative results, 7 laboratories failed to report the heterozygous deletion, and they used methodology that would or should detect that deletion. A further 9 laboratories failed to report the deletion and didn't state the methods used for the CMV analysis, or as a limitation, shall I say. So in other words, they didn't state that they didn't do CMV analysis. And then there were a number of laboratories that reported the deletion, but incorrectly, and to the extent of the deletion it's actually found. And finally, there was a number of laboratories that reported false positive and false negative results. So one laboratory found an intergenic fusion and reported it as a VUS, and another laboratory looks like it made a potential sample swap with case 2, and we'll talk about case 2 in the next couple of slides. Next slide, please. So in summary, there were lots of problems with detection of this deletion. A small number of laboratories are still making systematic errors with how they describe the deletion. In this case, we've got 2 examples here. So exons 1 to 3 and exons 5 to 12. i.e. there's no exon in the custom nomenclature that some laboratories are using. So this is really a question of custom versus legacy nomenclature for BRCA1. So we gave deductions to those laboratories if we detected this type of error. And the deletion itself extends outside the transcript. And so according to the use of HGVS nomenclature, a genomic reference sequence should be provided when you're defining the extent of the variation here. So again, some key learning to the laboratories here about how to use the appropriate nomenclature to describe the variation that you're finding within the gene of interest. Next slide, please. Looking at the interpretation of this variant, so good to see there were no critical interpretation errors associated with it. But as I alluded to right at the start, we included this sample deliberately for the reasons that we really do expect laboratories to be using a copy number variation test as part of this germline strategy. And a number of laboratories didn't do that or failed to recommend further testing for large genomic rearrangements. In some cases, the reports were just very unclear. It's very difficult for us to ascertain whether they had performed CMV analysis or not. In those cases, laboratories lost marks because of the ambiguity in the reporting information they gave. But the other most common reason for losing marks in this context was failure to advise genetic counselling or follow-up of the patient, and or failure to provide a version number for the kits that are used. So for example, MLPA kits are versioned, and each different version may or may not have a different strategy in terms of what probes it uses and whereabouts in the genome it works. So it's really important in the context of any kit you use to make sure you include the version number of the kit, not just the kit itself. In all those cases, laboratories lost marks if they didn't include that information. Next slide, please. So case 2 was a gentleman who'd been diagnosed with metastatic castration-resistant prostate cancer, received chemotherapy and hormone therapy, but the disease was now progressing. So there was insufficient tissue for testing, so a germline analysis has been requested, and he was being considered for targeted therapy using PARP inhibitors. So the question here is first-line chemotherapy, hormone treatment, and subsequent progression. And is there a pathogenic variant present in his germline DNA? Next slide, please. So in this case, the sample contained a heterozygous variant for BRCA1 that was predicted to lead to premature truncation of the protein, and no pathogenic variant detected for BRCA2. And the errors reported this time, so 98% of laboratories got the genotype correct. So the error rate, the critical genotyping error was 2%, which is much more in line with what we would see typically in most of our EQA schemes, somewhere in the region of 2 to 4%. Next slide, please. So when we look at the detailed analysis of the types of errors laboratories are making in this context, again, very similar to the previous slide, 2 false negative results where the lab failed to report that BRCA1 variant, 1 false positive and false negative result in the same context, so missed the BRCA1 variant but reported a different BRCA1 variant and no cDNA change. And then 3 reporting errors. So in this case, the laboratory reported a BRCA2 variant, which is probably, and then results incorrect for the reference sequence used. So in this context, they provided one reference sequence but got the results wrong because they'd used the wrong reference sequence compared to the expectations. And finally, there was another BRCA1 variant detected reported here as well. So 2 laboratories reported that one BRCA variant. So multiple laboratories use protein nomenclature defining the particular protein described here, which was incorrect using the HGVS guidelines. So again, HGVS is very clear about how you should report this type of variant. In this case, the incorrect protein nomenclature was used in the ClinVar entry for this variant. So it's kind of, we include it because it's highlighting a problem we do see with the use of the databases, which is basically, you really do need to check the information that's provided in variant interpretation databases just to make sure there's consistency for the same variant that you're testing for. In addition, some laboratories also reported the predicted protein change of valine 1713 frame shift instead of valine 1713 termination, which again was incorrect, and the laboratories lost marks for that incorrect interpretation. Next slide, please. A number of laboratories also fell foul of the, I would say, common HGVS 3' rule. So again, the way you interpret this rule obviously has a bearing on how you define the end result for the protein, the protein itself, the amino acid, shall I say. So you can find, I mean, the summary report provides a very clear explanation of why this is the case. And if you go to the HGVS website, it also gives you a feedback about why you should be using the 3' rule. And some laboratories also reported C.5137 del G. Again, it's about defining how you actually interpret where you measure the extent of the deletion associated with it. So these, again, the laboratories are falling foul of how they interpret the HGVS guidelines. So again, for both these cases, I would strongly recommend that laboratories go and reread the HGVS guidance on defining deletions and how you use the 3' rule to define the first base of the deletion. Next slide, please. As in case 1, great to see no critical interpretation errors. And really the most common reasons for deductions in this case was very similar to case 1. So failing to recommend follow-up testing for the patient or further genetic referral for genetic counselling, and also failure to define correctly the version number of the kits used. So small deductions, but key points that are really necessary in a clinical report, particularly if it's going to be read by multiple different clinicians, or it's going to be read as part of a history of the patient's record. Next slide, please. Finally, case 3. So the last of the 3 cases. In this case, it was a gentleman who'd been diagnosed with pancreatic ductal adenocarcinoma, which had metastasized to his liver. He'd been treated with platinum-based therapy for 6 months and has stable disease. His father also had pancreatic cancer, and the gentleman was now being considered for treatment using a PARP inhibitor or a targeted therapy. So the rationale, in this case, this was a pancreatic scenario, maintenance therapy after response to first-line treatment with platinum-based therapy, i.e. the individual hasn't responded. And the question we're asking is there a pathogenic variant present in his germline DNA? Next slide, please. So no pathogenic variants were expected to be detected in either BRCA1 or BRCA2. And the good news, or the good news take-home message from it, is everybody got that result correct. Move on to the next slide, please. Looking at the interpretation of the result, we did detect 2 critical interpretation errors. Now, this is not uncommon for us to see. So quite often we would see over-interpretation of the result in the context of a scenario where the patient has not got a pathogenic variant present. Not unusual for us to see these types of errors, but nevertheless, we're flagging it up for the laboratories. That's why we tend to conclude these types of scenarios. And the common reasons for deduction outside of those 2 critical interpretation errors were the same as the first 2 cases. So failure to report further follow-up, and also version numbering for any kits that are used in the associated process. Next slide, please. So looking at our scoring summary for the case, you can see that here you've got the 3 categories we score across the 3 cases. And you can see that the genotyping results reflected in the results, and the blue bars, lower scores for cases 1 and 2, and a very high score for case 3. And that interpretation for cases 1 and 2 is higher than for case 3, which we've just defined because there were 2 interpretation errors. And clerical accuracy hovers around near perfect, which is what we'd like to see and expect to see in the context of these types of cases. Next slide, please. Finally, looking at the performance data associated with this scheme. So here you can see the data presented for all of the scheme for the scheme since 2016, and on the left-hand side, the participation data. Now, what we're looking for here is the blue bar to be up and or close to 100%. If it's not, that means there are 2 reasons why laboratories haven't participated. In the grey bar is withdrawing from the EQA scheme and letting the EQA scheme organisers know. And then in the purple bar, it's the laboratories that don't submit results and don't tell the EQA schemes that they've done so. Those labs in purple would get poor performance on the basis of non-participation, and the laboratories in grey don't get poor performance because they've informed the EQA providers up front. What we want to see is that those two blocks come down massively, including the non-submitting results. And at the moment, typically over the years, it's hovered around 10%. So better than the last couple of years, which is great to see. Looking at the overall assessment scores, you can see that the genotyping scores is down on previous years, reflecting the large number of errors we've seen with the copy number variant testing, but also with the SNV as well. On the flip side, though, those laboratories have been reporting the result, have done a better job this year. So the interpretation scores have improved year on year, pretty much year on year, and there's definitely a trend to seeing improvement in the interpretation, which is a really positive thing to see, particularly given the diverse geographical nature of the laboratories participating. In the critical areas, you can see that we've defined the samples that we've tested we've provided a CMV analysis. And you can see that the genotyping error rates for CMVs is generally high, and accounts for a large amount of the critical errors we detect in those years. So the error rate this year was substantially higher than last year, where we didn't include a copy number variant. So a big reminder, as I said before, if you're doing germline testing, you need to be doing CMV analysis. Do read the latest best practice guidelines for that. Looking at the poor performing laboratories, Again, the data you see above on critical error rates is reflected in poor performance. And we had 12 poor performing laboratories this year. Most of them made mistakes in just one case, but one laboratory made critical errors in 2 cases. So again, those rates were higher than we've seen in previous years as a percentage of the participating laboratories. Okay, next slide, please. Okay, I'm going to hand over to Sandi, who's going to give you an overview of the somatic testing.
Great, thank you, Simon. So next slide, please. So we're going to follow the same format as Simon did for the germline testing. Oh, I think my video is frozen, so bear with me. Hopefully it will come back on. So these are the demographics of the participants for the somatic BRCA and HRR gene testing EQA that was provided in 2023. I think the take-home message here is we are seeing a continued increase, just like the germline scheme, of the total number of participants. And again, we're seeing more new labs coming on board, but those who have previously participated are retaining their participation year on year. So you can see here the dark blue lines on the graph on the left-hand side have continued to increase, which is great news. Again, we can break down where the participants are located across the globe. And I think the first thing to say is we have got global reach, which is fantastic to see. We have over 50% of the participants are based in the EU. And then, as with the germline scheme, we've seen an increase in participants from China. And there you can see the increase is up to 21% for the Chinese laboratories in the orange part of the circle. So next slide, please. Delivering a somatic EQA for this type of testing is challenging, and we have to think about different issues. Simon very eloquently went over some of the challenges in germline testing, and here we have to look at how we adapt the EQA approach to make it fit for purpose for assessing somatic testing. So the challenges are really for the laboratories to get good quality DNA, non-fragmented, from actual tissue samples. So the way that we can mimic that is we have to ensure we have the same material, enough of the same material to go to all of our participants, so we can do that benchmarking that I mentioned at the beginning of the webinar. So we provide FFP, so formalin-fixed, paraffin-embedded material, because we want to ensure that we can assess the extraction part of the process, because that's just as important as the testing accuracy. We also get quite a few laboratories coming back asking for repeat samples, or potentially reporting fails, not obtaining a reportable result. And we do track these, and if there's issues with the laboratory, potentially with their DNA extraction protocols, we can offer help and support for that part of the pipeline. Another challenge is we have a range of different laboratories participating, which means that we have different approaches to testing strategies. So we need to make sure that we are able to deliver EQA regardless of the way that you deliver your actual clinical testing. So we expect both BRCA1, BRCA1 and BRCA2 to be tested. And we deliver the germline and somatic testing with a range of different clinical scenarios. So for example, regardless of whether a laboratory performs their tumour testing first or their germline testing first, we're trying to incorporate that into our clinical scenarios. We also have variable experience in interpreting variants, and we see a lot of that through a lot of our variant interpretation EQAs. So what we try to do is provide a range of the different variants and different classifications. So again, it's mimicking some of the clinical cases that are coming through a clinical service. And we do perform expert review of the classification evidence prior to the EQAs being distributed. I think something that's really quite unique in the somatic testing arena for this type of EQAs is about understanding the laboratories, understanding the importance of the potential germline variants. So it's not about assuming that any variants that are detected are somatic. So we include this in the marking criteria, and then we extensively discuss it within the EQA summary report and this webinar. So next slide, please. The samples that we provide, as I said, are artificial FFP samples, so we're trying to include the extraction process into the end-to-end assessment pathway. We select them for specific variants, so we know the results that should be expected. And then post-sectioning of the blocks, all the samples were independently validated using next generation sequencing by 2 laboratories, and this is prior to distribution. So very similar to the germline approach, EQA approach, but what's important is we need to know that we know the answer from the sections that we actually are sending out for the EQA. And any material that doesn't meet the doesn't concur with the 2 different sets of validations and the known expected results, then they are not used for EQA purposes. So our first validating lab tested using a custom CIC QIAGEN panel on an Illumina platform, and the second laboratory used an Illumina NovaSeq 6000 with an enriched SNIP probes for that enrichment part, and then they looked at the entire coding sequence and the splice sites. So we obtained consensus in validation results, which were mapped to the expected data. So thank you. Next slide. So again, we've got 3 EQA cases to go through. So we start off with this lady who had been diagnosed with serous ovarian cancer. She had received platinum-based chemotherapy and her tumour had not responded. And she was now being considered for maintenance treatment with targeted therapy. So here it's about maintenance therapy after first-line treatment with a platinum-based therapy. That is the rationale for the case. So the question is there a pathogenic variant present in her tissue samples? Next slide, please. So the results were that there was no pathogenic variant detected in BRCA1, but there was a SNV detected in BRCA2. The good news is 98% of participating laboratories correctly reported this result, but we did have 2% reporting a critical genotyping error, so the wrong genotype for this lady. Next slide, please. Now, the reasons for that, as we've seen with the germline scheme, are either false negative results, and this is the most commonly reason for these genotyping errors, where basically the BRCA2 variant was missed by 4 laboratories. 1 laboratory failed to describe the variant, so failed to describe it as being a pathogenic variant and given more information, so that was deemed to be a critical genotyping error. And then we also had sample swaps and misannotations, so the results were incorrectly attributed to the wrong patient. So we're assuming there's been a participant laboratory swap at some point, and 2 laboratories, unfortunately, had reported that. So this laboratory didn't describe the pathogenic variant. To go a bit further into that in a bit more detail, so they didn't characterize this variant. So they put a general statement of pathogenic variant was detected, but really there was no information there as to what variant, the details of where it was located and the clinical impact or the predicted change at the amino acid level. So really the clear take-home message is that the characterization of the variant, not the deletion here, or further testing should be advised to enable better interpretation of the variant. So in summary, if your assay doesn't give you that information as to what the actual variant is, then you should recommend further testing so that is characterized in more depth. Next slide, please. We had a range of different small deductions through the interpretation category for assessment. Many laboratories did not have patient-specific interpretation on the report. The interpretation on the report, if there were interpretation comments there present, were very generic and often gave a range of different scenarios that if X is detected in this patient, then Y is a clinical indication, and a raft of different ranges of that, which really just pads out the report to make them quite long and unwieldy, but also hides and masks where the real true clinical interpretation should be picked up. So it just gets lost in the whole wealth of information on the report. Often there was no statement around the implication of this test result for other family members. And it's really important to help patients understand that genetic counselling is relevant for family members, and there may be an impact for those wider family and relatives. laboratories are still not providing interpretation which would aid looking at what the impact of that result is. So it's about providing your methods, describe it accurately or adequately. Also, very importantly, the limitations of the test or the scope of the test. Now, these deductions weren't quite as pertinent for this particular case because a pathogenic variant was detected, but we'll touch on that a bit more when there's no variants in the sample. Also, there was insufficient details regarding variant classification systems on many reports. Now, there's mixed views about whether this is required on the report or not. Many laboratories have that information, but it's retained internally within the laboratory. But it really depends your local practice. But it is good practice to list which classification system and possibly which criteria were applied to determine that this variant was pathogenic. So next slide, please. Moving on to now case 2. This lady had a platinum-sensitive serous ovarian cancer, and she's had surgery and had received 1 round of platinum-based chemotherapy. And now she was being considered for maintenance therapy with targeted treatment options. So the question here really was about maintenance therapy after responding to first-line treatment. So is there a pathogenic variant present in her tumour sample? So next slide, please. Again, we saw very, very high genotyping accuracy. We had 96% of participants reporting the correct variant and 4% reporting a critical genotyping error. So this case, again, we had a pathogenic variant present, but again, this time it was in the BRCA1 gene. And we also had no pathogenic variants detected in BRCA2. So next slide, please. So if we start looking at the reasons for these critical genotyping errors, we can see here, again, we have the 3 common reasons for errors. False positives, where one laboratory incorrectly reported the presence of a BRCA2 variant, and one incorrectly reported the presence of another BRCA2 variant. We also had 2 laboratories reporting false negative results, so they missed BRCA1 pathogenic variant. And then again, we had results incorrectly attributed to the wrong patient. And this with 9 laboratories, which is a high number of laboratories to really have mix-ups or inaccurate reporting of the results. The good news is, interpretation-wise, we had no critical interpretation errors, and really the small number of deductions were the same as those I've just described for case 1. So next slide, please. So moving on to the final case for the somatic EQA, this was a gentleman with castration-resistant prostate cancer that had metastasized to his bones. So he's had hormone therapy and chemotherapy and is now being considered for further treatment by targeted treatment. So the clinical case here and the reason for referral was about maintenance therapy after first-line hormone therapy. And is there a pathogenic variant present in his prostate tumour? Next slide, please. So this is a case where there was no pathogenic variants detected in either BRCA1 or BRCA2. And we were seeing a high incidence of good, accurate genotyping being reported by the laboratories. So 97% of their participants correctly reported that no pathogenic variant was present. However, we had hovering around again, the 3% mark, laboratories reporting a critical genotyping error. And if we move on to the next slide now, you can start to see the reasons for these errors. We had 2 laboratories reporting incorrect false positive results. So they reported a presence of a BRCA2 variant and a BRCA1 variant. And in fact, the BRCA2 variant was 2 variants present in that sample. And we also had the same 9 laboratories with the incorrect results being reported for that patient. For the interpretation, we had 1% of laboratories with critical genotype interpretation errors, which totals to 4 laboratories. And really the main reasons for these deductions were very much similar to those seen for cases 1 and 2. Next slide, please. So just looking at the scoring summary, it's always quite nice to have an overview of where we are with genotyping and interpretation in errors and deductions, and clerical accuracy as well. So I would say generally we have got very high standards of testing in the somatic area, but with more interpretation deductions being seen this year than we have seen previously. But I think that can be seen across the board with all 5 cases. Probably didn't help that 9 laboratories had misreported their data according to the EQA cases. So I think that has dropped quite considerably the percentage of performance. So next slide, please. Again, as Simon did with the germline scheme, we can actually have a helicopter view of the performance trends over the years that we've been delivering this particular EQA. As with the germline scheme, some participants do not submit results, and we really want to encourage the laboratories to participate if they have registered, because we also are often oversubscribed and we have a cap on the number of participants we currently can accommodate. Hopefully we can change that going forward. So really it sort of means that some laboratories who do want to participate are not able to do so. The genotyping, here you can see it's pretty much hovering around the same standard as previous years, and it is really quite high. It's very near that full two assessment marks for mean scores, and interpretation really does hover up and down, and I think that really is dependent on the clinical cases that we put into the EQA. Again, you can see the critical error rates. Predominantly, these tend to be genotyping errors right from the outset from the 2016 EQA. Poor performing laboratories, this year you can see there's been an overall drop quite considerably compared to last year, where we had a huge number of errors being picked up across the scheme. I think we can see that see the spread of errors really are across the different EQA cases. There wasn't a common theme that one in particular was more challenging, but we can see also a small number of laboratories reporting errors for 2 cases and unfortunately for 3 cases. So I think there's still room for improvement there, but it is definitely moving in the right direction. So next slide, please. And I'm going to hand back to Simon now to talk about the prostate cancer cfDNA testing EQA. Simon.
Thank you, Sandi. So yes, on to the last the last sub-scheme, if you like, which is on prostate cancer testing using cfDNA. Next slide, please. So we've only been running this scheme for 2 years, so the data here is presented for those 2 years. And I guess the key point to take home from here is that the numbers for this scheme are very heavily capped. So in the first year, our scheme was of a pilot. We were capped at 50, and this year we capped the number at 75. But what is good to see, there's about a third of the laboratories that participated this year participated in the initial pilot, with the remainder being new laboratories who hadn't been exposed to this EQA scheme before. Looking at the distribution, so as Sandi alluded to previously, we see from the germline and the somatic that we have a global coverage of laboratories participating in this EQA. The big trends, I guess, if you look at the trends here, are a significant increase in laboratories from China participating in the second scheme, and a corresponding reduction in the laboratories from EU participating. But I think we need to add a caveat here that there's obviously a capped participation of registrations. So if we were to open it up more, I think we'd see a settling of those numbers more to what we would see with some of the other 2 schemes. Nevertheless, interesting data in terms of regional distribution of participants from the scheme. Next slide, please. So looking at the challenges, there are 2 points I really want to flag up here. A lot of it's very common to the somatic context that Sandi reported to for the FFPE. There are 2 areas that really stand out for this scheme that are challenging both for the laboratory and for us to provide the EQA. The first one is really around high quality cfDNA. So I'm sure, as many of you are very aware, the availability of reference materials for plasma testing, cfDNA testing in plasma, is small. And as an EQA provider, we are, because of the availability of real clinical samples, we're very heavily reliant on using artificial reference materials to deliver these EQA schemes, and therefore ensuring that every laboratory gets the same type of sample or gets the same sample to test. So we put a lot of work into working with various reference material providers to ensure that we provide you with high quality cfDNA samples for testing. And of course, the other caveat here is that we need to make sure that the matrix, the plasma matrix we provide that sample to you in, has to be stable at ambient temperature to allow us to distribute that sample globally, rather than shipping on dry ice or cold chain storage, which of course is very, very expensive to do so. The key point here again is that using these types of materials were very easy for us to track sample failure rates, and the sample failure rates in this scheme were very low, which is good to see. So we think we've provided this year. Last year the material was perhaps more of a questionable, but this year provided a lot more samples that are a lot more robust and work really, really well in most laboratories that tested them. The second thing is really understanding the limitations of cfDNA testing itself. And again, we need to be able to provide samples that more closely mimic the real life scenarios. So, you know, these materials are complicated. The types of tests that are being used are predominantly next generation sequencing tests, so a scanning technology, a gene scanning technology, rather than a targeted regional test that you might get in other different test scenarios. So our samples need to be able to work with this type of approach. And we're also looking at, you know, the context of how laboratories do all their pre-analytical processes associated with it. So, for example, using inappropriate test strategies for pre-analytics based around FFPE extraction rather than specific pre-analytical processes dedicated to a somatic approach using a plasma-based matrix of material. The other challenges are very common with the somatic testing context. I'm not going to go into the details, but again, variable experience in interpreting the variants itself, and also understanding the importance of germline, potential germline variants in this type of test. Next slide, please. So the samples we provided this year, again, 3 samples provided. Artificial cfDNA, we used materials that we manufactured with Senside in Germany. They contained 80 nanograms per mil of cfDNA in a total volume of 3 mils of plasma per sample. We have obviously all the manufacturing data associated with this, so we can be pretty confident that the samples which were manufactured to the relevant ISO norm will deliver that amount of DNA in an ideal, perfect extraction scenario. We selected variants in BRCA1 and BRCA2, 2 different variant allele frequencies, either 10 or 50%. And those variants themselves were validated by the manufacturer using droplet digital PCR. But as we alluded to, we've also validated those materials externally before distribution to the laboratories. So we used 2 different laboratories to do that. One used a custom hybridization panel, a next generation sequencing panel, and the other one used an NGS capture-based approach using an automated Magnus platform. So our rationale for delivery of the particular genes used was based around the EMA licensing for these drugs. So at the moment it's restricted only to BRCA1 and BRCA2, so therefore we didn't include any other HRR genes in this year's pilot EQA scheme. And as it is a pilot scheme, there were no performance measures associated with it, and so there was no poor performance for laboratories as standard, as per our normal EQA schemes. And this, as I alluded to earlier, was the 2nd year of our pilot EQA. Last year, we were really trying out this methodology for delivering robust samples to the laboratories that would work in different strategies and ambient temperatures. This year, I think, you know, with a larger number of laboratories, the methodology was properly tested in this round of the EQA. Next slide, please. So looking at the cases, case 1 was a gentleman who'd been diagnosed with metastatic castration-resistant prostate cancer, received chemotherapy and hormone therapy, but now his disease was progressing. So insufficient tumor tissue was available for direct somatic testing, so CFD analysis has been requested, and he's been considered for treatment with a targeted therapy. So the rationale behind this is a prostate cancer scenario. He's progressed after first-line hormone treatment and chemotherapy, insufficient tumor tissue available to do a somatic test. cfDNA testing has been requested with regard to appropriate use of targeted therapies. Is there a pathogenic variant present in this sample? Next slide, please. So the results, there were no pathogenic variants present in BRCA1 and BRCA2. Of the 75 laboratories that participated, 98% of laboratories correctly reported the result as no pathogenic variant present in either BRCA1 or BRCA2. There was a 2% critical genotyping error rate, in line with the numbers we reported for the other schemes as well. Next slide, please. So looking at the reasons for genotyping errors, there was one false positive result where the laboratory reported a BRCA1 variant in the sample right at the start of the first coding exon. And in addition to that, one laboratory also received a deduction from their genotyping score for reporting a VUS, but discussing a clinically significant mutation. Obviously, the discontinuity between their reporting a VUS and saying it is pathogenically a significant pathogenic variant present. Next slide, please. Looking at the interpretation, so I think this kind of mirrors what we saw in the germline as well in this context. One critical interpretation error from the laboratories. In addition to that, there were 11 laboratories that overinterpreted the lack of a clinically actionable variant in the cfDNA of the patient. So this scenario is particularly pertinent to the cfDNA context. So the amount of cfDNA present in the sample may be a reason for a normal result, but not necessarily. So these laboratories incorrectly suggested there was no response for a targeted therapy, and further confirmatory testing should be suggested in this context. So where the laboratory didn't make that statement, the caveat essentially, they received a small deduction as a consequence of that. 20 laboratories, so 36% of the laboratories didn't suggest repeat testing may be appropriate in this case, either in another cfDNA sample or alternative in a tumor biopsy, and therefore received a deduction. And finally, there were several laboratories that didn't provide sufficient details of the methodology, limitations of the test performed, and/or the scope of the assays. And we'll talk a little bit more about that in the general recommendations, but we have been very clear in the report to laboratories about additional detail we would expect to see on the clinical report to cover this point specifically. Next slide, please. So case 2 was a gentleman who had metastatic castration-resistant prostate cancer. He'd been treated with hormone therapy and is now progressing. So cfDNA testing has been requested to determine his eligibility for treatment with targeted therapy. So in this context, we're asking a very similar question to the first. There's insufficient somatic tissue available, and is a pathogenic variant present in his sample. Next slide, please. So in this case, we were expecting laboratories to detect a pathogenic variant in BRCA2 at 10%. So the material for this case was manufactured at a 10% VAF, variant allele frequency, which had been revalidated by the manufacturer using droplet digital PCR. The validation data from the 2 labs we alluded to earlier using NGS had detected the variant at 8% and/or 10%. So you can see there's a little bit of variation with respect to the external validation laboratories variant allele frequency detected, but nevertheless within the region we'd expect to see, which was the 10% from the manufacturer. 87 laboratories correctly reported the variant, and a further 13% of laboratories failed to or reported a critical genotyping error. So if we look in the detail of why they made mistakes, next slide, please. We can see there were 5 laboratories failed to find the pathogenic variant, so a false negative result, and a further 2 laboratories reported a false positive result. So one laboratory incorrectly reported a intronic variant, BRCA2 variant, and another laboratory reported a BRCA1 variant. So broad range of errors made, but the false negatives obviously account for the largest proportion of laboratories, large proportion of mistakes made. Next slide, please. Look at the interpretation. There were no critical interpretation errors. One laboratory gave an indication of the pathogens, getting no indication, should I say, of the significance, the pathogenicity of the variant they detected, and received a deduction. A further 6 laboratories, or 11%, didn't provide sufficient detail of how they classified the variant, and received a comment. Again, very important here to make sure that you do state what you do in terms of the classification. What guidance did you use to do so? And if you are not already a participant in our BRCA variant interpretation EQAs, then I'd strongly suggest that this would be getting involved in those EQAs would be a good idea. The next run, I think, is in the autumn. In this case, there was a pathogenic variant, BRCA2 variant, as we've described, and it's possible that that variant itself could be of germline origin, and therefore we were expecting laboratories to refer the patient to either clinical genetics or request a sample for germline analysis. 11 laboratories, or 20%, didn't do this, and we fed back to those laboratories directly. One laboratory recorded a misleading comment, as they suggested that the variant allele frequency they detected could be used to infer the germline or somatic origin of the variant. But due to technical and biological reasons, the variant allele frequency is not necessarily a reliable indicator of whether that variant is germline or somatic in origin. So we would strongly, obviously, recommend that laboratories consider the importance of how they actually consider the origin, and you really just refer that sample for appropriate germline testing as a consequence. Next sample, please. Next slide, please. Getting mixed up on my samples there. Case 3 was a gentleman with castration-resistant prostate cancer that had metastasized to his bones. He'd received taxane-based chemotherapy and hormone therapy, but is now progressing. So like the other 2 cases, being considered for targeted therapy, and a cfDNA test has been requested. So is there a pathogenic variant present in this sample? Next sample slide, please. So in this case, we provided a BRCA1 variant at 50% variant allele frequency. Again, we're able to tightly specify the exact frequency that we provide this variant at, and the 2 validation laboratories both detected it, but slightly lower than the 50% we'd expect to see from the Droplet digital PCR data. So 42% and 44%. Nevertheless, the results actually were very encouraging. So again, we've got a higher variant allele frequency, so we would expect laboratories to be able to pick up this variant, whereas the previous samples at 10%, which is a bit more challenging than the 50% level of variant allele frequency. 95% of laboratories correctly detected this variant, with a further 5% making critical genotyping errors. And if we look at the reasons for the error, next slide, please. We can see the one laboratory recorded a false positive result, so they incorrectly recorded a different BRCA2 variant, intronic variant there. One laboratory incorrectly reported the variant, so they did detect it, but they called it a change of cis61 to arginine rather than a 61 to glycine. So found the right variant, reported it incorrectly. And one more laboratory got contradictory results and false positive results. So they described and interpreted the BRCA variant as both pathogenic and a VUS in the same report, and also reported an additional BRCA1 variant of unknown significance. Further, 2 laboratories described this variant as heterozygous, which of course is incorrect in the context of tumour testing, and these laboratories received a deduction as a consequence. Looking at the interpretation, there were no interpretive errors associated with it. Next slide, please. So looking at scoring, again, we can see pretty consistent results in terms of generally the quality of the standard of laboratory testing is good, but the interpretation, which was case 1, which is obviously the sample with no pathogenic variants, was more challenging. That's where we saw the errors from the laboratories. Next slide, please. And looking at the performance trends, so we alluded to the fact that this is the 2nd year of this EQA scheme. And in the first year, a couple of scenarios led to a large number of withdrawals from laboratories. One was the fact that the testing strategy used by labs is either not working sufficiently, and/or the samples we provided weren't as a true and proper mimic of the materials you would expect to find in the real scenario. And I think that's reflected in the large number of dropouts from that scheme, most of which were laboratories that actually withdrew rather than not submitting results. The data from this year look a lot better, in fact, massively better. So although there was about a 10% dropout laboratories withdrawing and another 10% didn't report results, the large majority of laboratories, over 70% of laboratories, got the samples to work very well, effectively for them, and reported results for the EQA. So we look at the assessment scores over the 2 years we run. So we're seeing consistently genotyping scores of about 1.8, which is good. Interpretation scores, the trends are too early to really tell what the trends will look like, but certainly the interpretation scores this year were better than they were last year. When we look at the critical error rates, again, the error rates this year are higher, double what we were seeing last year. And I think this is partly driven by the fact we're now using a sample where we provided a 10% variant allele frequency for one of the variants, much more challenging than we were providing last year. And this is really reflected in the genotyping error rate. And of course, it's a pilot EQA scheme, so there were no consequences of poor performance for the laboratory. So there's no data to report at the moment for that metric. Next slide, please. On to you, Sandi, for the shared learning from all three schemes.
Thank you, Simon, very much. So, oh, my video stopped again. Keep clicking. Can I just encourage anyone who would like to ask us a question to put that in the Q&A function on your Zoom, and we'll be very happy to do that after we've gone through the shared learnings. Thank you. So next slide, please. So we thought it'd be very useful to come together with a summary at the end of the descriptives of the EQA outcomes. And I think we wanted to start with the positive things, because often people just focus on the things that are either missing or the errors within an EQA. So I think we can say there's definitely been seen a high degree of compliance with HGVS variant nomenclature. This has not always been the case, and it's not always the case across other EQAs that we provide. So I think that is something that we can say has definitely improved over the years. As well as that, we're seeing an improved use of reference sequences. So we're looking really here for an appropriate reference sequence to be stated on the report, and only one per gene, and really starting to use the main and main select gene reference sequences that are out there. We're also seeing a huge improvement in the reporting format. We used to get many laboratories submitting multiple page reports. We're now getting to more concise 1 to 2 page reports. And really that makes finding the right answer and finding the clinical interpretation on the report much, much easier for the report reader. So next slide, please. But we do have still got lots of work to do in different areas of this type of testing. So one is variant classification. No surprise there. We see through our variant classification EQAs that it is difficult and challenging, particularly when there's multiple guidelines around, which often give different classifications for the same variant. So I think there's a lot of work still to be done, not just through education of individuals classifying variants, but also about how we go about it and which guidelines should be used. Many labs are still reporting the presence of non-pathogenic variants, that's class 1 and class 2. We really would like no class 1 or class 2 variants to be present on the report. They can be misinterpreted and potentially be used as that is a pathogenic variant being detected and be clinically acted upon. So it really is about preventing patient harm. Often the clinical question that's been asked is not addressed in the report. Often we have independent, multiple clinical interpretation included on the report, as I mentioned previously. So it's about having patient-tailored interpretation for the question being asked. That is really what is being looked for in the report. And then also when clinically relevant variants are not found in a germline sample, it's really important to recommend that a tumour sample should be tested to detect whether or not there's a somatic variant in that patient's tumour. Next slide, please. Also, it's good practice to refer patients to clinical genetics for further investigation or clinical genetic counselling if a pathogenic variant is detected in a tumour sample, because there is a chance there that it could actually be a germline in origin and not be a somatic variant. So it's really important that this is stated in some way in the clinical report that there is a potential impact on the family and the patient may have a germline variant. Also, we see this quite a lot in our cell-free DNA testing EQAs, that laboratories tend to overinterpret when there's no actionable variant detected. So it's about not over-interpreting this and assuming that there is no pathogenic variant present. It's more about, are you sure that you're actually testing tumour DNA in your assay? Next slide, please. Two of the areas of real concern from the EQA providers are many labs do not demonstrate full understanding of your limitations of your testing, and this is really apparent in the cell-free DNA EQA pilot. It's about technical limitations in terms of your analytical sensitivity or your limit of detection, but also about those other factors you have to consider about the biological considerations, about the levels, and is there sufficient tumour DNA present in the circulating free DNA in the samples that are being tested. Also, as we've both Simon and I've mentioned previously, is about providing details, appropriate and sufficient details on the method that is actually being tested. And I would say it's really important, particularly when no pathogenic variant's been detected. So the reader of the report understands where the limitations are and what may have been missed just due to the testing strategy being employed. Next slide, please. This, I'm not going to go through this, but it's good to share, and it's in our EQA summary report about how you go about describing the limitations of the assay being performed and how you can actually get that information across clearly to the readers of your report. Next slide, please. So key dates for what's coming online for 2024. Again, we're running the 3 EQAs as described today. We have our germline and our tissue-based and our plasma-based, so the 3 different sample types. The distribution of the samples will be in middle of September in 2024, with a return submission deadline in the middle of November. And then with all the data coming together and including the appeals process, we will publish the finalised results in the spring in 2025. So next slide, please. Thank you for listening today, and now we're going to open the webinar up to questions that have been submitted. We've got some coming through, so please do put your questions in the Q&A function. Simon, I'm going to kick off with one for you about the germline testing in particular. So we're now seeing laboratories being able to call more copy number variants from their NGS data rather than having to perform a separate MLPA test. Do you think we'll see an increase in CNV reporting going forward with our EQAs?
A loaded question, I think, but yes, the answer is yes. I would strongly like to see a large increase in labs doing CNV analysis. Of course, it's still challenging, even with an NGS-based strategy, and I think there's I think whilst in the germline setting it's quite well established, in other settings, particularly somatic setting, it's although being done, I think the jury's still out about the reliability of that analysis, partially dependent on how you get the sample, the somatic sample to test in the first place. I think it's also good to encourage laboratories to consider participating in the EQA schemes that we're running for both germline and somatic testing. We are now running another EQA scheme on CNV analysis in the germline context to get a real overview of how your testing process, your NGS strategy is working on a CNV analysis. But yes, I would like to see more laboratories doing it. I think we will see more laboratories doing, certainly in the germline setting. But I think from a laboratory perspective, over to you guys, we have been reminding laboratories about the importance of CMV analysis, particularly in the germline setting, and yet we're still seeing quite a significant number of laboratories making errors when doing so. So there's a lot more still to be done, and I don't think that's just dependent on the strategy laboratories are using. I think, you know, there's still errors being made even if they're not using an NGS-based strategy to do it. So yes, I think it's coming, and you know, if you are doing it, please do so, and please do participate in our other EQAs that target specifically this type of approach.
Yeah, great, thank you, Simon. So watch this space. Maybe next year we'll be talking about the massive increase in CMV calling.
Yes, I think it's likely. Certainly.
That would be good.
I'm very interested in, particularly in the somatic context, because obviously we haven't really covered that yet in the EQA, and I think that'd be an interesting area to see what happens in the future. Sandi, I've got one for you. So this should challenge your brain cells.
Oh dear.
Really, it talks about how the terminology of the word somatic. So the question is, concerning the erroneous use of the term somatic for variants derived from somatic tests, should we be using the word tissue test rather than somatic test to induce the idea that you find a somatic, that what you find is a somatic test? What do you think about the terminology used here? Should we be changing it from somatic to something different?
I think it's a really good point. I think terminology is always a struggle because often things mean different things to different people, and it's about standardization. I think we use the word somatic also when it comes to plasma-based testing. So it's about it being a derived, not an inherited variant. So I think the tissue test wouldn't actually solve that. But I think we have to get around a situation that you need to understand what you're testing and what you can report and what you're detecting, or you shouldn't be doing the testing in the first place. So I think it's about the understanding, and that comes on to actually the second question, which ties in about, which is from one of our delegates today, is how can one be so sure to consider the variant as a germline while only doing somatic tissue testing? So to be very clear, when you are performing your FFPE tumor tissue test on DNA extracted from that tissue, you are always going to get a percentage of normal, non-tumor DNA extracted from in your sample. And that is where your germline variant may potentially be detected from your assay. So you're picking up both somatic, as in acquired variants in a tumor, and your germline variants in your inherited nuclei. So it's about a mixture. It's often known as like the soup DNA, whereby you've got a bit of everything in there. So it's about not over-interpreting a variant and assuming it's actually coming from the tumor, whereby there's a possibility that it may be coming from the germline. And that's why a lot of assays either are very highly sensitive with low limits of detection, which means that they can use scrolled sections straight from your FFP block. But when assays are maybe not quite sensitive, then they rely on macrodissection, whereby you're actually optimizing the amount of tumor, so your tumor nuclei, into your extraction. So I think it's an issue about education, about what you're testing and what you can potentially pick up.
Yeah, I would agree entirely with you. And I think it's also worth pointing out to the participants that we are obviously aware that the samples we provide do not allow macrodissection of the tissue. Because we're using an artificial material, we cannot provide a sample that you can then macrodissect. But we take that consideration into account when we design the scheme. So when we've designed the materials we actually use, effectively you're getting material that's 100% tumor, and therefore highly enriched, if you like, for the variant of it, whether for any variants that we might choose to contain within it. But the other way of looking at it is you're obviously getting a sample that's probably better than the real life scenario.
Absolutely.
So again, it sort of emphasizes if you are making mistakes on these materials, it requires consideration of the impact of that on your real life testing strategy as a consequence. Okay. I don't think we've got any other questions. So would you like to draw it to a close? Or...
Yeah, we've got one more come in.
Okay, that's good.
So it's several labs appear to have reported kits without version numbers. So do you have any insights into why this might be happening? Were previous years' instructions clear on the importance of version control? Is it possible that some labs without version numbers are new participants? So I think, Simon, do you want to comment?
Yeah, very happy to comment on that. So this is not a new scenario we're reporting here. So we see this quite routine, and it's not just held within the context of these key EQAs we've been talking about. I think there's probably two things going on. So firstly, we have deducted marks consistently for this, for failure to report version numbers and kits routinely for quite a few years. So it's not new from an EQA perspective. Secondly, the relevance ISO standards are quite particular about making sure that you do include this additional information. So this is a full version of the type of kit you're using. I think it's possibly an impact. It may well be related to laboratories who've never done EQA before and therefore never been exposed to the level of oversight or critical oversight we provide on your reporting process. And I think it's probably worth saying that obviously it's a reflection on the amount of the thoroughness that we put into these assessment processes. This is sort of level of detail we will pick up. But it's important. It's a necessary piece of information you should be providing on your report. If you're providing a commercial kit, there are take MLPA, for example, there are significant differences between different versions of MLPA kits, which can have a real significant bearing on the end result for your patient. So you really do need to make sure that the end user is at least aware of what version of the kit has been used, and therefore by definition the limitations of that kit that you've used on that patient sample, and then reflected on the end result. So yes, it's really important to include it. There are lots of problems associated with it, but it's not difficult to do, and we would expect to see it on every report as a consequence. Sandi, I've got one for you, really relating to liquid biopsy testing. So considering the low specificity of this type of test, is a confirmatory or orthogonal assay test required to confirm the findings from the initial test? So, for example, a droplet digital PCR test.
Okay, I would say no. Your test that you're using for clinical service should be fully validated or verified, which means that you should have full confidence that what you're detecting is actually present, so that I don't think there's any need to do validation. Otherwise you would have to retest all your samples of all your clinical service. So as long as it's validated and you have you're assured that it is can pick up variants at that level, then I think you do not need to confirm by an orthogonal method. Would you agree, Simon?
Yeah, I would agree. And I'd also add that in the context of BRCA testing and HRR genes in general, of course, what the laboratory is doing is generally not a targeted test. And so in this scenario, if you were going to be doing confirmatory testing, it would have to be a strategy that could also do gene scanning, or you'd have to work up a completely new assay for a particular variant. Of course, many of these variants are not novel, but present at low frequency across a huge, big coding region. So I would agree with Sandi. If you start to go down the confirmatory testing of every variant you detect, it would be very difficult to manage in a clinical service.
Simon, one last question, and I'm coming back to you about version numbers again. So, but this is quite a pertinent question. It's about how much information you need on your report. So is version numbering necessary for established kits like extraction kits? So I think we need to be clear about what we mean about kits.
Yes, so very good question. So my opinion might differ from yours, Sandi, because we've never talked about this in any great detail.
No, we haven't.
I believe that the differentiator with most of these tests is the analytical part of the process. That's the most variable part of what you're doing in terms of the strategies used by different laboratories. So the test strategy used by laboratories, i.e. the kit used in the test that does the actual measuring of the variation within the DNA, definitely needs to include the version number. The pre-analytical process is a thorny issue, and I think it partially depends on on what you're actually testing. So for germline DNA and somatic testing, it's probably not quite so relevant as it would be in a cfDNA strategy, where you're clearly, you're extracting very small amounts of DNA from a liquid biopsy assay, which many laboratories do test within the FFPE. So I think you don't need it for the pre-analytical process, but you definitely need it for the analytical process. What would you say, Sandi?
I completely agree with you, with the caveat that the information is always held within the laboratory. So if you did need to go back, it would be the mere available. But I think which extraction kit you've used is not of any value to know that for the reader of the report. So I agree with you, Simon. Yeah. So as we've agreed, I think now we need to close the webinar.
Yeah, I think we do. Yes, absolutely.
So first of all, a huge thank you to Simon, my co-chair. A huge thank you to the participants and for those of you who have joined us today, and those of you who submitted questions as well, to Indigo Medical, the team behind the webinar, for all their help and support, and obviously AstraZeneca and MSD for their educational grants, and the teams back in EMQN and GenQA for all the hard work providing these EQAs. So thank you very much, and thank you for joining us.
Good afternoon. Thanks for everything.